So Dr. Gardner, we know that these are slow-growing tumors. Often takes a long time to diagnose them, and they're often in difficult places. Is there any evidence that operating on these tumors and removing them, doing a subtotal resection, is there any evidence that you make the remaining tumor more aggressive? Does it grow faster after you've been in there?
I think in the skull base, I don't know of any evidence that going in and operating on the tumor activates it in some way. Certainly you could come up with theories that the tumor doesn't like, the exposure to oxygen perhaps, but I have not seen an example of this. The question is the tumor discovered at a time when it's becoming more aggressive, and then perhaps someone operates on it and it continues in this aggressive pattern? Again, I have not seen cases. I'd be interested to see if there are sacral cases that you guys have seen, but I've not seen that in the skull base, where a tumor has clearly changed its behavior because of a surgery, even a surgery that was subtotal or an incomplete removal. And I can't think of a good theory behind why touching the tumor would do that.
In terms of a rationale for why the kinetics might change, you have a surgical wound with a lot of growth factors for repair of the wound, and I think it probably changes the growth kinetics in that setting.
When should a biopsy of a new diagnosis occur, and when should it not occur?
It's important to separate between spine and skull base.
I would agree, because a lot of and I think Paul would agree, that some of the skull base lesions that are radiographic classic for chordoma, you'll probably treat like that because of the morbidity associated with it.
We have a technique of going to the nose where we can land basically directly on the tumor. The risk of seeding is there. It seems to be a little bit lower in the skull base. It's probably around 1% to 2% with radical removal if patients will get seeding. We've had 2 cases out of 150 or more through the nose where there was seeding in the nose. We had to go back a couple of years later. But we haven't had that after biopsy, and generally at the time of surgery, we're able to see almost all of the tumor, which is a little different. For me to go through the nose and open the sinuses to see the whole tumor is different than opening what has to be done in the sacrum to see the whole tumor. So there's a little bit of a difference there in the skull base. The other difference is that it's very difficult or rare for us to be able to get around the whole tumor and remove the tumor and normal tissue in one chunk, which they can do a lot of times in the sacrum. So that's why there are differences there, and also why it's sometimes in the skull base you can do a biopsy in the same setting as you do a removal. So you can take a piece of it, know that it's chordoma at that time, and then go ahead with your removal through the same way you would do the biopsy. There are things that are done at specialized centers to avoid seeding, all the things you've heard the orthopedic and neurosurgeon talk about for the spine. For endonasal surgery, we've developed these little plastic sheaths that go in the nose during surgery, because the only 2 seeding we've seen have been on the front of the nose, which means it came from bringing instruments in and out, so now we have protective sheaths for that. So there are things that are done at sort of specialized centers to prevent this.
Related to the regrowth of residual tissue, perhaps Dr. Heery, there's a number of patients, as you know, who have damage to their pituitary gland, for example, related either to extraction of the tumor or to follow-up radiation, who then go on to require hormonal therapy. There's some concern that the administration of those hormones in the aftermath of having a tumor resected will in fact encourage regrowth of tumor.
We do know that hormones can affect both the growth of certain tumors as well as the immune response to tumors. Those tend to be very specific tumor types. They usually are associated with glands. I don't know of any hormone receptor overexpression on chordoma cells, and I don't know of any data that indicates that any hormone drives chordoma growth. In fact, there doesn't seem to be that those pathways are upregulated one way or the other. I can't think of a mechanism why that would be true in chordoma.
Loss of hormone function, which a lot of times in the skull base is inevitable after appropriate doses of radiation, has an impact on quality of life and, if not done properly, quantity of life. So people who don't have their loss of hormone properly treated do not live as long.
Yeah.
And so you really have to take that into account. Not only will you not feel good, you actually will have many more health problems if you don't have proper replacement. Now, things like testosterone and growth hormone get a little trickier because their impact perhaps is a little less, and there's some theoretical reasons why they could impact the growth of a bony tumor. But the fact of the matter is that these things are being done to replace what your body normally makes. And in general, without any evidence to suggest it's bad for you, there's a lot of evidence to suggest it's very good for you to have those normal hormone levels.
Yeah, thanks for bringing it back to the most practical point, which is you can't live without most of those hormones. So,
Testosterone.
I think whether you're at the skull base or whether you're in the sacrum, if you can get it down to fewer cells left behind, whether because at the skull base you can't always do an en bloc or resection with negative margins, but if you can decrease the number of cells so there's a gross total or fewer cells left behind, I think that's when radiation probably works best.
I think one of the issues, at least in the skull base with preoperative radiation, is usually the limitation for radiation in the skull base is how close it is to the brain or the brain stem. And one of the main things surgery does is get it away from the brain or the brain stem. And so that allows safer and more effective radiation because of that. The problem with Gamma Knife, at least for upfront treatment of chordoma, and I think part of the consensus statements were that radiosurgery like Gamma Knife is not part of the primary treatment, is that it doesn't treat the whole area where the chordoma was. And unfortunately, anyone who's had a chordoma recur know it usually happens on the edge of the tumor. And so if you just treat the little center of the tumor, you're not doing the proper treatment for that. And that's the problem with Gamma Knife, at least as a primary treatment for it, whereas protons treat the entire bed of the tumor.
There are cases that are 14, 15, 16 years out where you'll see a local recurrence. And that's why I went to the combination of using radiation plus surgery for some of the cases, because I haven't been seeing those recurrences greater than 10 years out, where in surgery alone I have. So,
Chordomas can recur late, and we've seen recurrences out beyond 10 years. So we've continued annual imaging, at least in our patient practice, as long as we continue to see the patient. For some other tumors where patients have isolated metastatic disease to the lungs, such as sarcomas, we'll cure patients with removal of the lung nodules. For chordomas, I'm actually not aware of any data that removal of lung metastases results in cure.
we have considered surgery in the cases, as Dr. Stacchiotti mentioned, really when there is some concern that that lesion is going to cause a significant event. So if something's close to a major vessel or an airway, or if it's growing in a disproportionate fashion to other sites of disease, then we would consider resection. And we have done that a few, about, I think, 4 times in the last year or so. But those are the exception, I think. For the most part, systemic therapy is our approach as well.
I would agree with that. I think lung metastasis happens in the setting of recurrence of the tumor somewhere else. It's that tumor somewhere else that's far more likely to cause a problem than the lung disease. In general, we observe lung disease. I don't treat it. I don't send it to a thoracic surgeon because they likely will remove it. But there's no, that's not the limiting thing for the person with the lung metastasis. It's wherever their local tumor is. Now, if there's something that's growing or threatening, then I agree, removal is the treatment. But in general, I would say the answer to that question is actually observation for lung metastases.
For me, it's the amount of nodules. So if it's just 1 or 2, it's a pretty easy decision. If it's 30 and they're not growing quickly, then we don't need to be as aggressive. We can actually take an observation-based approach. When they start growing rapidly, that's the time for systemic therapy. I totally agree.
Generally speaking, cytotoxic classic chemotherapy is today not considered an active drug, an active treatment for this tumor.
These treatments that Dr. Stacchiotti is talking about is not a typical chemotherapy where it has a lot of the toxic effects where all your hair falls out and all that kind of thing. It's more targeted for aspects of the tumor. Is that fair to say?
The surgeons really need very specific imaging techniques. And I've had patients say, well, they did an MRI last week, and you did one 2 weeks, why is it a different MRI? And the point is, the surgeon might need a very specific sequence of images and timing of contrast.
with molecular imaging, we're getting much better, hopefully, at imaging at least tumors in mice and things, and hopefully in there's some clinical trials now trying to be applied to some of these tumors. So it's something to think about for the future. Benign notochordal cell tumors have a different radiographic appearance, and when you take them out or deal with them, they're much harder to deal with because the tissue is unlike a chordoma that's more gelatinous. So we have been able to sequence fetal notochords and then isolate the notochordal cells using laser microdissection, and then doing sequence. You can even do single cell drop-seq to try to get data that may help you decide, like Paul was saying, is the progression that would then go on to a chordoma.
Chordoma has this really wide range of behavior. You can have these children less than the age of 5 who, no matter what you do, nothing controls the tumor. And then you have some people who actually follow a very small chordoma, and then when it starts to grow, finally remove it and never have another problem with it again. So there's this huge range, and most fall somewhere in the middle of it. But I think what it does point out, and one of the very important things that this foundation has done is getting to experts, so you don't, if you do have surgery, you don't have a incomplete surgery. If you're going to do it, you have, the maximal possible surgery you can have while still preserving best quality of life, and that's a very fine line to get that treatment right.
So let's turn to pediatric cases for a minute. Because we're seeing more and more cases in younger people, even in babies. The question is, how does the behavior of pediatric chordomas differ? And do newly diagnosed pediatric patients need to see a different set of specialists? Perhaps we'll start off with Dr. Stacchiotti, and Paul, perhaps you could weigh in there.
Children under the age of 5 are much more likely to have a dedifferentiated type of tumor, and just dedifferentiated just means it's uglier, it's got far more mutations, it looks less like a typical chordoma because, and it behaves much less like it. And those tumors tend to be much larger when they present as well. They look different on MRI, they have more cells in them, and they tend to regrow no matter what you do. And probably those children still need surgery to remove as much as possible, but they probably are the ones who most desperately need some type of chemotherapy. The way we manage pediatric chordoma is that we do all of the care with a pediatric neurosurgeon. So we enlarge our team by adding not just our skull-based team, but adding a pediatric neurosurgeon, because there are a lot of different considerations in children that are necessary. And I know there are a couple of other groups that treat it this way, and I think that's the appropriate way. You combine an expert who understands the disease with someone who understands, the child.
There are 4 types of chordoma. You have a conventional chordoma, which is the most common. A chondroid chordoma, which has a cartilage component, is found more often in children. So are the poorly differentiated, which are different than the dedifferentiated. And the poorly differentiated are those that do respond and have you find more in children as well, and will respond to neoadjuvant chemotherapy.
You've heard about T brachyuria that you've heard a number of times. So T is still expressed in poorly, but not in dedifferentiated. So there's some biology there where it's lost expression and looks more like a sarcoma under the microscope. The poorly differentiated type also has loss of this gene called INI1 almost universally. It's part of the epigenome, and we have some targets for that I think will be interesting. But I don't know what's happening in Europe, but I think we're going to start moving towards chemotherapy and radiation only for these types. That's my guess, just based on my own experience with these patients and some of my colleagues. But we'll see. It's still early days.
So we actually became interested in brachyuria for nothing related to chordoma. And without Josh, we never would have known to put patients with chordoma onto that study. So that study was originally intended to focus on patients where we had observed brachyuria expression in small nests of tumor cells. So we are developing those vaccines in other tumors actively. We have planned studies. Some of them are going to be multi-center studies, that will be run by the companies that we work with. Does it benefit chordoma to see that this could work in other? Absolutely. And can we also learn something about the biology in the cells that express brachyuria that are not chordoma? And we think so, and that is an area of research in our lab.
Do we consider chordoma a benign tumor or a malignant tumor? And is there any point in time like they do with respect to prostate cancer, do you consider a time where you would not treat the chordoma?
It's a malignant tumor. And then in terms of patients who wouldn't necessarily need to be treated, there's certainly some experience with skull base, and occasionally we'll find incidental lesions in patients. Sometimes we're not sure if someone has a chordoma or a benign notochordal tumor where there's a lesion within the cortex of the bone. We'll observe those patients.
The comparison to prostate cancer is a really interesting one because they are really opposite ends of the diagnostic spectrum. Chordomas almost always are found because of symptoms, and prostate cancer, over 80% of the time, is not because of symptoms. We actually know the prognostic indicators in prostate cancer fairly well, of which patients are likely to do very well and which patients aren't. And chordoma, I don't think that's quite as clear either. So
I think that goes back to the spectrum of disease. There very well may be this very small percentage of chordoma that's sort of an inactive, benign precursor to the more malignant versions of chordoma, but in general, most chordoma is malignant when it presents. I think that's part of our understanding. As you say, it's taken decades to understand that about prostate cancer, and that's a disease that is extremely common. This is a very rare disease, and I think a lot of the work that's going on will help us understand it genetically and maybe someday identify that small percentage. But as a general rule, it's a malignancy, and if anything, unfortunately, sometimes it ends up undertreated.
In the literature, till a few years ago, you could find, and many doctors were used to say to the patient, this is a benign tumor. But this is not a benign tumor and has to be treated at the first presentation to try to cure the disease, because in case you cannot achieve this kind of cure, becomes very much more difficult to approach the tumor later. So it has to be treated really as a malignant tumor, even if the local relapse is more common than the distant metastatic disease.
In the skull base, the risk of recurrence was maybe approximately about 30% in the first 5 years, and then maybe another 20% over the next between 5 and 10 years. Protocol we've adopted has been MRI imaging every 6 months for the first 4 to 5 years, and then annually. Then in terms of chest surveillance, chest X-ray alternating with a chest CT. Our sense is the majority of people who would have metastasized by 5 years.
Anyway, I think we need to disclose that among the experts, there is not an agreement on which is the best follow-up timeline and approach. And this is one of the paragraphs in the new position paper that is rewritten by all those who are reviewing the paper, because there is not an agreement, because nobody was able to prove that to anticipate the evidence of the relapse can improve the prognosis.
We're learning. That's what's happened over the last 5 years through the Chordoma Foundation, is what we know is 1 million times more than we knew 5 years ago. And it's because of willingness to participate in these studies that may give you no answer and may not help you, but it does help the science, and it helps all of us learn, and that helps chordoma treatment be better.
Can we give a hand to our panel?